Do you have SIBO and want to learn how to help yourself? The SIBO Success Plan is now available from thesibodoctor.com. In this highly anticipated plan, you'll learn my tried and proven method to treat SIBO, including home treatments, online dispensary guides, diet handouts, and much, much more. Already being treated by a practitioner? No problem. The SIBO Success Plan is designed as a standalone program or to work under the care of a practitioner. Become a SIBO-savvy patient and beat SIBO for good. For more info, go to www.thesibodoctor.com. Welcome back to part 2 of the SIBO Doctor podcast, and let's jump right back into it.
Yeah, so usually when we say something's studied for Prokinetic, it's not about constipation. Oh, actually, I could see what you might have thought, though, because prucalopride, actually, one of its main indications is for chronic constipation. And so that has been studied for producing a bowel movement, actually. But that's at dose between 2 to 4 milligrams. And we use it at 0.5 milligram. And I do just want to say this, if I haven't said it already, a Prokinetic could give anybody a bowel movement. And also, I mean, yes, because this category is a category of medicine that is trying to amplify GI movement. However, if we think about all medicines, like what is one of the most common side effects of any medicine besides headache would be diarrhea. So that's just a common thing that can happen from any medicine. And I just wouldn't want people to get too upset about that. Like, it could happen because it could happen from anything. And if it does happen, there's 2 things you can do. You can either lower the dose or just switch to a different Prokinetic. Because this is a big issue, which I'm sure you were going to bring up at some point anyway. People worry with diarrhea, can I take a Prokinetic? And you can, because it's not meant to stimulate a bowel movement and usually doesn't. It's meant to stimulate the migrating motor complex in the small intestine. And one more thing on this, which is a hard concept, really for anyone, but especially for patients that don't have any training in this, is that you can have diarrhea of the large intestine, but yet SIBO in the small intestine with slow motility. Slow motility in the small intestine, which is giving you bloating and SIBO, and then the SIBO is causing diarrhea down in your large intestine. So these chambers have different motilities associated with them.
Yes, and in fact, one of the reasons why you get diarrhea with SIBO is basically because of the overgrowth of bacteria that are then triggering a release of fluid through the small intestinal wall to try to flush out all these bacteria. So it's not a motility issue sometimes. It's basically just the body's defense mechanism trying to clear this overgrowth. But really what caused it is the slow motility. Now, that is really another area where I think a lot of education is necessary, because a lot of times people don't have a problem with motility. It's not always, I don't think that SIBO is always caused by a problem with the migrating motor complex. And
Absolutely.
And I sort of divided it into 4 categories of causes of SIBO based on underlying factors. And so the main category, without a doubt, of causes of SIBO is the category of dysmotility or something having caused a problem with motility. And one of those, which Dr. Pimentel thinks is about, 60 to 80% of all SIBO, which I would possibly debate. In my clinical experience, it's perhaps less than that. But people developing SIBO after a case of gastroenteritis or food poisoning, the classic post-infectious IBS, that damages the migrating motor complex. And that's really been the topic of his research for many years now. So, but other categories include more where bacteria are not properly cleared from the small intestine, and that could include things like endometriosis and adhesions, where you can't actually, there's just some adhesion causing a kink in the garden hose and nothing can move through. And so that,
like obstruction, that's how I think of it, obstruction.
Yeah, sort of partial potential obstruction. And this is where you and I had a conversation with Dr. Razai, who's a colleague of Dr. Pimentel's at Cedars-Sinai, about a very interesting case of giving Prokinetics to somebody who had adhesions, and that patient actually getting worse, because the issue was not motility. The issue was that she couldn't clear things through this sort of partially obstructed small intestine. So, just as a reminder for practitioners out there that there are different underlying causes that will help you. If you understand what's caused the SIBO for your patient, that will help you determine whether or not this patient needs Prokinetics. Because I've had patients with endometriosis that really did not require Prokinetics at all. So just as a reminder that not every single SIBO patient will need Prokinetics.
Yes, and in fact, when people get sent for an intraduodenal manometry test, which is the official way you would test for the migrating motor complex, it's not readily available. But if somebody has an obstruction, partial obstruction, some kind of obstruction, in fact, they will see the migrating motor complex waves working overtime. Mm-hmm. That is if that person has the ability to have migrating motor complex waves. Of course, there could be a scenario where someone has damaged nerves and adhesions, and is messed up in both ways. But they'll see this and they call it MMC-like waves. And it has a distinct pattern where it's like there's extra of them and they're coming faster. It's basically just trying to push against that obstruction.
Mm-hmm. Yes. So for those practitioners that actually have access to the test, it's a blood test. It's called the IBS Smart now. That tests for antivinculin and anti-CDTB antibodies. That's highly recommended that you do that on your SIBO patient, because it'll really tell you in black and white whether or not this person needs Prokinetics. And that's good to know because they don't often work forever. You sometimes have to rotate, don't you, Allison?
It's true, yeah. And actually, there was something I just wanted to say that test, the IBS Smart, newest generation of it, that's an indirect test for the migrating motor complex. If it's positive, then it's not working well. Mm-hmm. But yes, erythromycin and ginger, both I have seen tolerance develop to. I've also seen people where they haven't developed tolerance to it, but I've more often seen it with those. I've also seen it with prucalopride. And in those cases, what we usually do is take the person off of it for at least 2 weeks, put them on something else. And then often when we come back to it, it will work again.
Good to know. Okay, so now I'd like to kind of discuss a little bit about the different types of SIBO and who may need Prokinetics. And I kind of in my mind pull up that slide that pretty much, at every conference, Dr. Pimentel brings up this slide. The one I'm talking about with the 3 circles and 2 of them are overlapping and one of them is by itself, and that's IBS-C. So for those of you who've never seen this slide, basically Dr. Pimentel, who we keep referencing to because he really is probably the most engaged and active SIBO researcher. Would you agree with that, Allison?
Oh God, yeah. Oh yeah.
So he really has brought this whole topic into the limelight, and his whole mission is to educate gastroenterologists so that they don't always immediately jump onto colonoscopies on people for people that have these types of symptoms. And that really, bless his heart for having done all the work he's done. So basically, this slide is it's 3 circles. 2 of them are overlapping, and one of them is by its lonesome self. And the 2 overlapping circles are basically diarrhea-dominant SIBO, mixed-type SIBO, and then SIBO-C or constipation. And so what I always remember is that he talks about that it's kind of, they're starting to think of methane-dominant SIBO as sort of a different condition. And that really resonated with me because I find that methane-dominant SIBO patients do react differently. There's just something quite different about that. Also, what he's talked about is that those that have methane-dominant SIBO are much less likely to have had a case or have their SIBO be precipitated by a case of gastroenteritis or food poisoning, which is not like the most common kind of SIBO, which is the diarrhea dominant, that is very much linked to these antibodies and to post-infectious gastroenteritis. And so the reason I mention this here is because in lecture after lecture, he talks about that these prokinetics, especially prucalopride and all of that, are really most indicated for the IBS or SIBO, diarrhea or mixed type, rather than the methane type. You've had a sort of a little bit of a different experience, but we've talked about that we do see very complex patients that are, sometimes defy logic in many ways. What has been your experience of all of that?
Well, I think the difference that you and I were identifying is, well, I'll say first what my experience is, and then what maybe the difference is that I find that prokinetics are needed even more so for my methane patients. Like, it's just a gold star, fabulous. It helps them so much, so much. And in their case, it also helps them with their constipation. In this case, we're usually using it for symptomatic relief as well, usually in higher doses than we would just for SIBO relapse prevention, along with their laxative. And actually, one note on that is that the studies that were done on prucalopride, I found in a lot of my methane patients with constipation, I would need to use prucalopride and magnesium, and I felt like, am I failing here? What's wrong? Why can't I? Why do I have to use both of these? What am I not? These cases are hard, and methane is generally harder. But then I read a study that they said that in fact that had been looked at, and they found it was a wonderful combination, and it made a lot more patient satisfaction with constipation when they used both, actually. So that's what I found, and particularly because I feel that I have seen a lot of methane patients where they really do have problems with their MMC. And oftentimes I was using prucalopride, and I'm saying that because I had gone down the pathway of using various things, but these patients were so advanced, I had to use what was really the most effective. In fact, often a lot of these patients were on prucalopride at night and erythromycin in the morning. I just found that over time, the prucalopride, I really felt like it was kind of healing, like Dr. Pimentel talks about this, like healing their migrating motor complex. He talked about it with, and then I'll come back to the differences here, but he talked about it with his food poisoning patients. So we would suspect here non-constipation patients and he was using a different medicine in the beginning that then got pulled from the market, and that was tegaserod. And it has the same mechanism of action as prucalopride, although prucalopride is more selective, which makes it safe. And he said that over years of using it, he felt like it was actually healing people, and they would heal from SIBO by using it. And then he switched from that to prucalopride when tegaserod was taken off the market. Well, anyway, I feel like I've seen that in a lot of my methane patients, but not full healing, but like really improving them over time. But what I think is different that we might have identified is that I haven't carved out the group of methane patients that have only methane and that start high and stay high, which is a group that you've been able to identify in your practice is quite different. And you can speak more to this, but I think you were saying that's the group that you felt that maybe prokinetics wouldn't be needed for.
Well, in terms of, yes, so in a nutshell, yes, that's true. In terms like methane that starts high, that stays high, sort of more potentially like a LIBO effect or large intestinal contribution, let's say, and rather than a mixed type where we see hydrogen and methane be high. But really, it's about whether or not the migrating motor complex was damaged in terms of if that person has had either a post-infectious gastroenteritis. And many of my chronic constipated patients with methane do not recall ever a really serious episode of food poisoning. And so that really also was contributing to this thought that I had that methane, there was always something about methane that didn't sit right with me. And that is that the majority of people in Africa are positive for high methane. That would actually be classified positive SIBO methane. And they're not constipated, So for me, plus as we get older, methane naturally rises, and many people are high methane and are not symptomatic. So that partially has always bothered me, that this is not a pathogen. And as I sort of dove more into the research of methane, there's actually sort of also positive effects of having Methanobrevibacter smithii on board. So there's just a lot more that we need to understand about the different types before we jump on, before we really kind of, well, I guess what I'm trying to say is that I do think that that Methane Sibo is overdiagnosed and overtreated. And whereas maybe if we focused more on large intestinal contributing factors, people would be spared a lot of these treatments. And so, after years of doing this, that's the conclusion that I'm coming to, because I am not like people that have high methane stay high. I don't treat them like SIBO. I treat their large intestinal dysbiosis with very good results. So anyways, that's a whole nother discussion. But it's an important discussion to have as we talk about prokinetics, because here is a class of patients that may be spared a whole class of medications that they may not need. Although in your experience, you've had very good experience with prucalopride and constipated patients. Was that at the lower dose, or was that sort of at the higher dose?
In fact, and even with the other prokinetics, but in fact, to your point, it's because we were targeting large intestine. Mm-hmm. We were targeting bowel movements by altering the dose strategy.
Mm-hmm. Yeah.
Which is either a higher dose for the pharmaceuticals or with the herbals throughout the day, not just taken at night before bed, but like taken 3 times a day, like morning, midday, and then at night before bed. Mm-hmm. So, and the other thing that stands out to me from what you said is the methane patients that start high and stay high with no history of food poisoning. Mm-hmm. So that could be the distinguishing factor there. Because what I was mentioning to you is, granted, I do see very rare cases, rare meaning they're more challenging, because as a specialist, they wind up in the specialist's office when they're different, right? Different. And so I have seen many cases of, not like tons, but, more than 2 handfuls of constipated patients that test positive for having had food poisoning on that test. And even some patients that don't remember ever having had food poisoning. But I believe that that's rare. I just think that I've seen it more commonly because that's what comes to me. So I think what your point about that is really well taken, that could be another really distinguishing factor. It's the methane patients that start high and stay high that really don't have an exposure to food poisoning.
Mm. And mixed type, that's a whole other investigation that needs to occur. Mixed type and the diarrhea type, which the diarrhea type being the most commonly associated, I think, with food poisoning. Okay.
Absolutely.
Very quick, I want a couple more things that I want to cover. One is in terms of when to start prokinetics. And I just want to remind listeners, because I've mentioned this before about prokinetics. This is something that also resonated with me when Dr. Pimentel said, when you treat your first patient, or let's say you treat your patient for the very first time for SIBO, you've completed antimicrobials. They are now, you've retested, they're completely clear of SIBO. Dr. Pimentel has recommended in the recent lectures to actually wait with prokinetics, unless you have a really documented case of antibodies, but to wait with prokinetics until the first relapse to determine the length it takes or the amount of time it takes for that person to relapse. Because if it's 6 months, it might be better off for them just to get retreated for SIBO once or twice a year rather than being on a prokinetic the whole year. I just wanted to kind of preface this section of prokinetic talk. What are your thoughts about that, Allison?
I think that's brilliant. I love it. I had heard him say recently that he was doing it differently. And the other reason why I think it's not even so much about Prokinetics, but the other reason why that's good is because this would be like the patient that's never been treated before, right?
Mm-hmm.
Is you don't know, are they going to be a 1/3 non-relapser or are they going to be a chronic? How do we know? We have no way to know that. And symptom severity and length of symptom actually doesn't predict it. So we if we've treated them and their test is clear or their symptoms are 90% better, then we should see which they're going to be.
Mm-hmm.
So I think that's a brilliant.
Okay. Did you have any other comments about, you did in your lecture also talk about combining prokinetics.
That is for more difficult cases, like I was mentioning, prucalopride at night, erythromycin in the morning. So, if you're not getting all the effects you want and need out of the prokinetic, particularly in terms of relapse, like I have patients that relapse every 4 weeks, pretty intense. And so to lengthen, we do all kinds of things to try and lengthen their remission time. And usually these people have multiple incurable underlying causes. So then we will layer them and try different ones. If I've done, like one thing I love to do is LDN plus iberogast. I like that one, particularly because when you're titrating the LDN up at first, I like to have another prokinetic on board because it takes a while to get the LDN to the right dose. So I'll do things like that. Also, iberogast and ginger are a wonderful combination, or a ginger-containing formula, because iberogast does not contain ginger. So that's a nice combination. Where the main way that I meant it is for when you're struggling with the remission, being too short, the relapses. However, you can also do this when you're trying to treat symptoms. Like you might use ginger or iberogast in the day for some symptomatic relief. And then you might use, LDN at night as your sort of your prokinetic, so that's okay as well. The reason this is okay is because they all have actually differing mechanisms of action from each other. And that's why it's okay to sort of layer.
Okay, fabulous. Okay, last question. And this is a question that you and I get so often, don't we, Allison, about what is safe to eat. Well, let me back up and set the stage a bit more. What we know is that the migrating motor complex works best or starts working about 90 minutes to 2 hours after meals, right? And what we want to do in SIBO treatment is have periods of fasting in between meals, so no snacking, to allow the migrating motor complex to work better. And the common question that we get is, well, what kind of non-caloric things can I drink, beverages, or what can I eat, or that won't actually stimulate the migrating motor complex? So over to you, Allison.
Well, I got all this information from Dr. Pimentel because, I've read studies on it, and some of them are quite controversial. And actually even contradict some of my patient experience. And so anyway, I just asked him because he does these studies with antroduodenomanometry, testing the migrating motor complex. And so I will just tell you what he has said in terms of eating and drinking. He said that calories stop the migrating motor complex. So a meal will stop it for an hour and a half to 2 hours after you begin eating. But if you had something small, like a piece of candy, then that would only stop it for 40 or 50 minutes. He said artificial sweeteners, and this is the one that is really like, oh no, including stevia, can turn the migrating motor complex off because they can bind to gut receptors that indicate a meal it has occurred. So, a lot of our patients like to use stevia in beverages between, and he is saying that's not a good idea. Do it with would be okay with your meal. But he also said that stomach distension, which is anatomical, meaning like a lot of fluid or food went in there, will turn it off because the baroreceptors indicate a meal. But so here we don't mean distension like bloating and distension. That is not the same thing. And then drinking too much too quickly. So he said if you were to take 1 cup of water or some black coffee or tea, those things are allowed. If you sip them like over a 15-minute period, that's okay. But if you were to take a whole cup of water and take it all at once, that could turn the migrating motor complex off because of that stomach stretching. So, and everyone always asks, can I have coffee? Can I have tea? So he's talking about black tea and black coffee. So coffee without any sweetener or any creamer or milk or anything, because they all have calories in them. And, he's never made a comment about herb tea. So I don't know the answer on that one. And if we just step away from that for 1 second, there's 2 other things that could turn the MMC off, and that would be sympathetic stress. And there actually are studies on that. Because the MMC is more of a parasympathetic nervous system component. So that would mean things like worrying, fear, anger, like basically rushing, fight or flight could turn it off. So that's important, very important for us to remember.
Yeah, I'm so glad you mentioned that. That's like so important in this patient population for sure.
Particularly because SIBO causes anxiety. So it's extra important that we work to bring our stress down and our worrying and also rushing, which is just ubiquitous. And then the other thing is the cephalic phase of digestion. So the sight and really concentrated thought and smell of food, or even the taste of food as it's in your mouth before it reaches the stomach. So I think most people are not necessarily sitting around in between meals really thinking hard about food, but, like maybe you are, but most people are concentrating on something else. But just technically that can turn it off. So those are the things we know that can turn it off.
So important. Thank you so much for that summary. I just have so many more questions, but
let's do at least one more.
Okay. Well, actually, they are bigger questions that I think would that we're just going to have you come back to the podcast, because it's so wonderful to have you here. It's such a wealth of knowledge. But I'd love to also just give a moment to see what your current projects are and where people can find you. I don't think you're seeing patients at the moment. Are you?
No. I've been taking a hiatus while I got some projects done. And so one of the exciting ones is I finally have as you mentioned, I teach SIBO at University NUNM and have done so for 6 years. And so finally that will be online, although it's actually expanded from what I teach in university. As a practitioner training, it'll be a continuing education and also certification. So I'm very excited about that. And if you sign up for my newsletter, so SIBOinfo.com is my free educational website, and if you sign up for that, you'll get notified. And then I'm also been working on a book this whole time since 2010 when I first started into SIBO, and I'm very near to the end. And I actually decided, I thought I was going to self-publish for a long time, and I've encouraged many of my friends to self-publish, but now I have actually signed with a publisher. So it's
fantastic. Congratulations. When can we expect this? Yeah.
Well, I would imagine in about a year, if everything goes well. I mean, I feel like I'm like a contractor. I'm famous for giving a deadline and then not meeting it, which I hate. but I work really hard every day, so I'm really trying here. But anyway, there's that. And as obviously your diet, the biphasic diet is my SIBO specific food guide put into phases and some slight adaptations from it. And I had actually worked to update that. I'd worked on it for 2.5 years, updating it, and never shared it because of some legal concerns, because I wanted to actually pay for it, because I've spent all this time charge for it because I spent all this time on it, and I would really love some financial compensation for my work. So I think I might have actually just recently figured out what would make sense legally. And so that will probably have to wait till after I get the book out. But so, maybe soon after that, that will come out. And then I just am very excited for that. So these are the things. Oh, and actually also the other thing I've been doing is, I found I see very challenging patients, obviously, and I found myself frustrated, like many of us are, with my options for treatments and things to do. And so I've actually been investigating alternative new treatments for SIBO, and particularly underlying causes. I've spent years studying underlying causes, really trying to understand it, and I've done lectures on that, and obviously that's come out into the public sphere quite a lot now. We all talk about them now. And so I've really been looking at treatments that can help with underlying causes. And so I'm looking to probably have some kind of, mini conference or something where I can have speakers on this to help all of us practitioners learn these new methods. So anyway, that's what I've been doing.
It's super exciting. So once again, SIBOinfo.com is the website to go to for Dr. Allison Siebecker. Allison, always such a pleasure. I really consider you a good friend of mine and a great colleague. And I'm so thrilled that you're getting so close to finally putting something out in the world that you can get compensated for. So very excited for that.
Exactly. All of these projects will have, fees attached to them. Amazing.
Yeah, I know. People will not be used to it. But, and just for those patients listening, Dr. Allison Siebecker has truly been one of the most generous people with information and making it available for free on her website. So we are eternally grateful for that. And I think it's about time that you do get compensated. But anyways, enough about that. I do feel it's been really fantastic. I think practitioners and probably patients are going to get a lot out of this lecture. So thank you once again for coming on the podcast.
Thank you.
Thank you for listening to the SIBO Doctor podcast. We hope you found the information in this episode useful in the treatment of your SIBO patients. Thanks to our sponsors, SIBOtest.com, a breath testing service with easy online ordering, and Quintron, maker of outstanding breath testing equipment. Tune in again for another episode of the SIBO Doctor podcast. Thanks again for listening.